Today's webinar is titled Top Priorities for EMS Education Research, presented by Dr. Scott Lancaster. I'm going to pass it over now to our presenter. Scott, thank you so much for being here today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you, Rio. And thank you to the National Association of EMS Educators for inviting me to present the research paper entitled Defining Priorities for Emergency Medical Services Educational Research. This paper was published in the Journal of the American College of Emergency Physicians Open in January. It is an open access journal, so anybody can go ahead and look it up in JSEP Open and take a read of the full study, but we're just going to talk about what we did, why we did it, and where we think we can go from here. So first, just to start out, why did we do this study? This study was a work in progress for a handful of years. There had been some minor studies done, minor research done to look to see what was out there for evidence-based education, specifically in EMS. And as people were looking, they were finding that some other healthcare professions have educational research agendas done, and there's been some pretty decent research in some allied health fields about their specific education. Respiratory therapy and nursing specifically have some pretty good studies out there about what works well and what doesn't in primary education of those professionals. But what we never found was educational research agenda for EMS specifically. Now, there are research agendas for EMS that are out there, but they're more looking at the clinical portion of EMS. And we felt missing the boat because we didn't have anything that we could talk about how we train our providers before they get to the clinical field and they start taking care of patients. So we decided that we were going to launch a research study to find an evidence-based approach to EMS education. As we talk about evidence-based medicine all the time in healthcare now, but we really should be talking about that as well in the educational space. And that was an area that we just found was lacking. Another reason why we thought having a research agenda published was because, you know, honestly, research is not cheap. It does take some expense either in labor hours or in actual cost to have the systems to crunch the numbers, the expertise of the personnel to do the analysis and produce the papers. And research dollars are limited. So, you know, having a foundational research agenda that could tell us what does the field say needs to be researched, we thought that was important, and we wanted to put this out to everybody in an open access journal so that people would have full access to it in EMS. So our objective of the study was to define and rank research priorities of EMS education in the United States. There are educational research agendas from a couple of the Commonwealth countries out there already, but EMS in the United States is very unique compared to a lot of the other Western EMS systems, and our educational model is also very unique. You know, in most of the Western world, EMS education is university-based. It tends to be longer, tends to be more in-depth when it comes to pathophysiology, biology. So we wanted to see what did our providers in the United States think would be, what is missing? What are the gaps in our knowledge about how we educate our providers in the United States? So what we did was a modified Delphi study, and it was a kind of a two-phase study that we conducted. First, we did a kind of a cattle call where we put out a pre-Delphi survey that was pushed through social media channels. It was pushed by a couple different professional organizations and was open to anybody who wanted to respond to it in the EMS workforce in the United States. We took the data from that study to create the second Delphi panel, and complete the second portion of the study. The second part of the study was a purposely selected panel of EMS educational experts from throughout the country and throughout different stakeholder groups. So we looked for educators from trade schools, people who do primarily continuing education, people who do primarily primary or initial licensure education. We looked to the fire service, we looked to the military. We kind of tried to do a broad catch to see if we could get a pretty good cross panel of EMS educators in the United States. And then we conducted a 4-phase Delphi panel to rank the top research priorities in the United States. So the pre-Delphi survey that we sent out just asked simply, what are the top opportunities or challenges in EMS education? And we asked them to consider both initial and continuing levels of education. From that initial pre-Delphi survey, excuse me, we received a total of 463 unique responses from educators, which included over 2,000 submissions. So we had over 2,000 data points to pull from that initial survey to help us build our initial Delphi survey. So one of the things that we did with the initial survey was we received all those 2,055 initial responses. Then we conducted a thematic analysis to kind of come up with what we were seeing to create our Delphi survey for the panel. Also, one thing that we did was we decided that for the actual Delphi panel itself, we wanted a minimum of around 30 EMS educators to be part of that panel. That number was purposely chosen. The research has shown that a panel greater than 30 doesn't really improve the validity of a Delphi panel. So we wanted to recruit at least 30 people. We recruited 32 and had 32 responses in the first 2 rounds of our Delphi survey. We did have a little bit of loss to follow up as we continue through the survey, and that's very common in survey research and in Delphi panels. It is a little bit time consuming, and it's a lot of back and forth via email to get people to respond to the surveys and the follow-up prompts to the surveys. So we initially had 32 that participated in round 1 and round 2. We lost 2 of them in round 3 and another one in round 4, but that's fine. 29% or a 91% retention rate in our Delphi panel was still statistically significant for us to be pretty happy about the validity of the results we were getting out of the survey results. Just to note that if people did not participate in round 3, they were not invited back to round 4. So they had to continue through each stage of the process for them to be continued in the additional rounds of the Delphi survey panel. So in round 1 of the panel, we asked the educators simply, what are the top 3 knowledge gaps involving EMS education that should be priorities for the future of research? And again, consider both initial and continuing education. Another thematic analysis was conducted at that point, and for the people who are attending who have never been involved in a qualitative research project, thematic analysis is where you take the responses and you try to group them into themes, and then from those themes you keep drilling them down to come up with your next set of questions for your panel. In round 2, we took that thematic analysis, and the question was, what knowledge gaps involving EMS education that should be priorities for future research are missing from the list? So we gave them the first list back after the thematic analysis and said, what did we miss? You know, one thing with thematic analysis, while it is a rigorous scientific method, it is qualitative research, and there's always a chance that something got missed. Maybe the investigators could have, there's some assumptions that get made in thematic analysis. We wanted to make sure we didn't miss anything that the Delphi panel thought was really important to be included in the following rounds of the survey. So we sent back the round 1 thematic analysis and said, simply, what are we missing here? Is there anything that we are missing from the list? Once we got the round 2 results back, another thematic analysis, everything was combined, and then we put the themes into a 5-point Likert scale, and we asked them to basically just score them. We were using mean scores to identify each knowledge gap, and then from that we ranked the top 30 gaps. It's not identified in the paper, but we initially had over 70 that we had to drill down. And one thing that's interesting is, of the over 70 that we had after going into round 3, where we drilled it down to 30 based on the mean scores were all really, really close. the difference gap between number 1 and number 74 was less than a point, or right around a point. So one of the things is the researchers felt that all 70 plus of the initial gaps are probably worthy of future research, but to make it a more meaningful paper and a little more condensed set of gaps for people to work with, we identified the top gaps with the highest mean importance scores. And in the final round of the survey, we gave them that top 30. We gave them the top gaps that were identified. And we once again asked them to rank. This time we asked them to rank order the top 10 gaps. As it says on the slide, a rank of 1 was most important and was given 10 points. A rank 10 was least important, and that got 1 point. So that can be kind of counterintuitive when you just read it really quick. But if you gave somebody a 1, we assigned 10 points. You gave them a 10, meaning the least important that was on the list, it got 1 point. And then we scored those all up. That's how the Delphi survey was conducted. And now I'm going to let you know what we found as we were doing the survey. Some of the results were interesting, actually, and really in depth. And I do encourage anybody who hasn't had an opportunity to read the paper to go ahead and go to JSTEP, open it and pull it. Again, it's open access. It's free. You don't need an account or anything. And take a look at all the gaps and all the sub themes that were found as well. I'm going to show you a couple of the sub themes that we found, but it was a pretty extensive list. It would have overwhelmed a PowerPoint. So please pull the paper and take a look. So these were the initial themes. And like I said, there are sub themes under these. I'm going to show you one in a second. But the themes that we came out with out of round 1 and 2 were competency and assessment, feedback, and verification. So basically, how are we assessing our students? How are we giving them feedback? And how do we know that the assessment tools we're using are valid? We looked at curriculum content, what's in the curriculum that we are teaching our students, the curriculum delivery or methods of delivery of the curriculum, what formats are being used, what technology are people leveraging to deliver that content, how is EMS education funded, what resources do people have? Remember, there's a wide variety of educational institutions in the United States, everything from graduate school level universities all the way down to trade schools. And in a lot of parts of the country, you'll have the training done by your local EMS or fire departments or first aid squads up in my area in some parts of northern New England. So funding can be a big problem for a lot of areas. One of the themes was educators, and that one was pretty in depth, looking at the different types of EMS educators. How do we decide who is an educator? What training or experience or education do our educators get or not have? We looked at the different ideas of students, the EMS profession as a whole, including public perception of the profession, how the profession is regulated, and does that have anything to do with educational outcomes, and then the regulatory burden and regulatory requirements that vary state to state. So under that theme, curriculum delivery, this is just a partial list of the sub-themes that we pulled out from round 1 and 2 of the Delphi survey under curriculum delivery. So just to talk about a couple of them briefly, bullet point number 3, association between EMS student skill performance during educational program and clinical performance after graduation. What I can say anecdotally is there's not a lot of data on that out there. You know, we as educators, we tend to look at our first attempt pass rates for initial licensure as a benchmark. We know that COA EMSP looks at that. It's a reportable thing for paramedic education. They have to report the first attempt pass rates annually. But does a passing the National Registry exam or a state licensure exam equate to good clinical performance in the field? And if so, where are we measuring that, and how are we measuring that? Is that 1 month out of school, 1 month as initially licensed, 6 months, a year? And what metrics are being used for clinical competency in the field? Very widely, and there's not a lot of data, if any, out there on what educational programs and what methods of education produce good clinicians in the field after licensure. So that is a gap. The use of evidence-based teaching methods is another one that I find really interesting, because I know when I started as an EMS educator, I had very little, if any, education in education. I basically tried to model the best instructors I ever had and then not follow the behaviors of the bad instructors I had, or the ones that I just didn't appreciate their teaching methods. But I came to find out after years of experience in education specifically, that I really just didn't know what I didn't know. So are we using evidence-based teaching methods in our classrooms? Are you using active classrooms appropriately? Are we using validated assessment tools in our classrooms so that we actually know if our students are learning, or are they simply able to follow a check sheet to pass a skills station? Also talked about, one of the sub themes was instructional design for EMS courses. And this last one, I would just want to talk about briefly, the effects of online versus in-person education on EMS student performance. We did this data collection during COVID. So obviously there was a big shift to a lot of online education. There was a very big shift to simulation instead of clinical time for students across the health professions. When we started this project, I was a dean at a college. I was the dean of health sciences at a college in Massachusetts. And I had nursing students, paramedic students, radiologic technology students, everybody who were doing simulated clinical time in our sim labs in small groups to maintain social distancing. They were doing a lot of their didactic online for the first time. And we honestly had no idea how that was going to go. In most of health sciences, online education is not something that was used broadly prior to COVID. So it was kind of a new paradigm for us. So that one is very interesting to me, and I don't think the data is out there yet. But I do think that that is something we should look at, because increasing, again, this is Scott personally speaking, I'm not speaking for the research team on the paper. I think that opens up a lot of opportunities across the country, especially for our more rural providers, because increasing online education, if we can prove that online education leads to similar competency and outcomes as in-person education, imagine what can be opened up to the vast majority of the land space of the country that doesn't have access to universities or high-end medical centers to receive continuing education all the time. So moving on to round 3 of the paper, where we identify the top 30 research gaps. And I have all 30 for you, 2 different slides to show you the different gaps and how they scored coming out of the top 30. So the first gap, that the gap, the highest mean importance score that was identified, was the effects of diversity and cultural humility among EMS students, educators, and professionals on equitable patient care. I'll be honest, that was not what I thought was going to be number 1 myself, but I knew it was going to be in the top 5. There's a lot of clinical research out there that shows that culture of humility and racial and socioeconomic differences do have an impact on patient outcomes. There are papers that have been published in index journals showing that patients of minority groups do receive, for instance, less pain control for acute trauma than Anglos do. And it didn't matter who the provider was. If the racial or ethnic or cultural background of the provider was the same as the patient, it didn't change how they were treated. So there is a gap in healthcare on how we are treating patients, and culture, humility, and understanding diversity is really a big deal in healthcare right now, and it should have been for a long time. So I do think that is an area that, while, again, I was surprised to hit the top mean importance score in round 3, it was something that I should have expected. It is a big area that we need to improve on, in my personal opinion, right now. What is entry-level competency of an EMS professional was another one that scored really, really high. And I see that now in my current job a lot more than I was when I was working as a dean at a college. Now I'm back in EMS full-time. There does appear to be a gap in what people think a newly licensed provider should be able to do and what they were really trained to do. What is entry-level competency? An argument can be made, it's passing your licensure exam. If you pass your licensure exam, you're entry-level competent. And I don't think that's a bad definition personally, but What does that mean in the field? What do we expect out of our new providers? And what ongoing training and education do they receive once they hit the streets, either through their FTO program or beyond that, orientation programs, once they're actual field providers? And again, you can see some of the other ones that popped up that were retained in the top 30. Behavioral health concerns and the amount of education that our providers receive. If you look at most EMT textbooks, the behavioral health section is pretty short, but behavioral health is a big amount of calls we go on. I'm sure people have seen all the controversy that's happened in some states where it comes to ketamine use and either agitated or excited delirium. But honestly, our providers don't really receive, at the median, they don't receive a lot of education on behavioral health emergencies. It's not a big part of the curriculums across the country, and that is an area of concern. And then another one that, just to cover a couple of these on this slide, another one that piqued my interest was the association of the EMS curriculum content with real-world practice and scope of care, including non-ambulance work settings. So one thing that has changed dramatically in the EMS profession in the 28 years I've been working in EMS is when I first became a paramedic, I really had one option. If I wanted to be a paramedic, I could work on an ambulance in my area, in the Metro Boston area. There wasn't anything else for me to do really as a paramedic other than be a 911 or an interfacility paramedic. That has changed dramatically. And it was changing pre-COVID, and it has definitely changed post-COVID even more. At least in the New England area, we're seeing urgent cares pop up on every street corner. They're all hiring paramedics to work in the urgent cares, and they're paying competitively to what the EMS agencies are paying. Offshore work, travel work for paramedics blew up during COVID. You could make thousands of dollars a week going to do COVID work across the country. You're seeing paramedics and EMTs being utilized in hospitals now more than ever before, especially in my area in New England, where it was very limited in the past. So there's a lot of things paramedics can do now that they couldn't do 10, 15, 20 years ago. But if you look at your standard EMS textbook, be it EMT or paramedic, it's largely based on 911 responses. So are we truly training our EMTs and paramedics of the future in our classrooms to be the paramedics or EMTs of the future in the field? Because I think the field has changed. So that's another area that I think is worth looking at. And again, this is a gap. There isn't a lot of or any research on this currently. This is just continuing that top 30 gaps. You can see that, again, culture of humility popped up in the top 30. And if you look at those mean importance scores, as I said earlier, you can see they're all pretty tight. So all of these are very important to the expert panel. We didn't have anything that really came back with like a score of like a 2. The initial Delphi rounds came up with some pretty decent gaps, and it was really hard to drill them down. Some of the things that are interesting that are worth studying: the association of EMS program accreditation standards with real-world practice and clinical performance. If any of the paramedic educators in the room know that if you want to have your students be eligible to take the National Registry, for a while now, you've had to either have been a KHEP accredited paramedic program or be under letter of review from COA EMSP. Questions have popped up of, okay, so they're doing that work. What is it impacting the field? That is a gap. I don't think there's any research on that shows that accreditation standards improve clinical performance. But there's no research that says it doesn't as well. That's something that I think would be very important for our educators to kind of drill down. Remember, if you're a member of a KHEP accredited program, you're part of KHEP. Changing their standards, they go out for public comment. We should be able to give our feedback and try to adjust our standards to improve real world performance. Again, is our goal just to graduate people with high first attempt pass rates, or is it to educate people who are good clinical performers in the field after they passed on the first attempt? I think our goal is the latter. It's to do both. We want them to be successful in their initial licensure exams, but we also want them to be good performers and be able to produce good outpatient outcomes. Patient outcomes research, which is clinical, is not covered in this, is also another area that, outside of a few topics like cardiac arrest, we don't see a lot of clinical research being done. There's been a lot more of it done recently, which is very good. ESO has produced a lot of good research based on clinical data. We just need more of it. How does simulation affect student performance? Again, this goes back to what I was saying earlier about that rapid transition during COVID. We didn't know what was going to happen when we switched people from having good hundreds and hundreds and hundreds of hours of clinical with real patients in hospital settings to doing simulation in a sim lab and talking to a mannequin for 6 hours. I'm a big believer in simulation training and education, but there wasn't a lot of data out there that was showing, does simulation produce good clinical outcomes, good education that leads to good clinical outcomes, excuse me. It just wasn't there. And it still isn't. So I do think that's an area that simulation has become very prominent in all of health education, and it's growing all the time. And I think we should look at it and see what ways we can improve or leverage it to produce better outcomes. One thing that I hadn't talked about much yet was also the characteristics of the educator or the program director. On the last slide, there was something that talked about program director turnover, which was sort of specific to paramedic programs. There's about a 33% turnover. About a third of paramedic program directors have been turning over year to year across the United States. This one is more looking at the workload specifically of EMS educators or program directors. You know, you can make an argument part of that workload goes back into the resources bucket as well. You know, there is a little bit of a gap when it comes to our standards. When I was working as a dean, I had 12 full-time nursing faculty and a full-time dedicated nursing director who did not have a teaching load. My paramedic program had 2 full-time people. They had the exact same number of students every year. So, and it was all funding. The reason why the nursing program had what they had was because their accreditor required it. The paramedic accreditors didn't require it. So it was hard to get the power brokers, the people who hold the purse strings, to give us more resources. And even though I was a dean and a paramedic, I struggled getting more resources for programs where I didn't have a duty on a piece of paper saying to do it. So I do think the workload can be a problem. Maybe that's part of the reason we have so much turnover. All right, so moving on to round 4, we took those top 30, we sent them back out, as I said earlier, and we generated a list of the top 10 prioritized research gaps related to EMS education. So these were the top 10. We can go through each of them a little bit. Characteristics defining entry-level competency, the EMS profession was deemed to have the highest ranking. And again, I think that's probably a good one in my personal opinion. I think there is a disconnect between what we think is entry-level competency as field providers and what is entry-level competency. And again, remember that in EMS, we are pretty much the only acute care allied health profession in the United States where people graduate, get licensed, have a very short, if any, depending on where you're working, orientation time, and they go to work. Residency programs are throughout the rest of healthcare. We have orientation and FTO programs as short as 40 hours I know of out there. So you're a brand new paramedic, you do 40 hours of third ride time, you're cut loose. And in some areas, especially now with the, I don't want to say paramedic shortage, but the misallocation of resources of the available paramedics out there, we have pretty new paramedics with very short third ride times who are working PV or in fly cars by themselves. And I do think that we need to redefine what is entry-level competency, and beyond that, probably what do we expect them to be able to do, and when should they not be alone yet because they are still at entry-level competency. Very similar to that, number 2 was the characteristics of EMS educator competency. There are a lot of different debates out there over what should be the minimum level of education required to be an EMS educator, and I think that's too broad of a question personally. I think the educator competency for a lead instructor in a primary education program, be that EMT, AMT, or paramedic, versus somebody teaching Con Ed could be different. And I think it could be different for many reasons. But what is EMS educator competency? just to elaborate on that a little bit, I can give you a little bit of my own personal history. I received my EMS instructor coordinator credential 20 years ago through the state of New Hampshire. And in New Hampshire, to become an EMS IC, you needed to take the National Fire Academy's Fire and Emergency Services Instructor 1, 2, and 3 program. Very long, very involved, a lot of work, but very fire-based. And part of that reason why we do that in New Hampshire is EMS in New Hampshire does fall under the New Hampshire State Fire Academy. It was a great program. In Massachusetts, where I currently am, there's a couple different pathways. You can take the NAEMSE instructor course, and that is considered an educational equivalent to a state version of their own instructor coordinator course. However, Massachusetts doesn't accept the National Fire Academy's Pro Board accredited program. So there's a big difference in what each individual state says you need to have in education to be an educator. And I think maybe we can fix that a little bit. I think if we could come up with a national standard, I think that would be great. But if we can at least define what we think different levels of EMS education need in their educators, I think that would be a good learning point. Just jumping down to number 5, the presence and effects of implicit bias in EMS education delivery. It actually was very interesting to me. I went through a pre-con at the NAEMSE symposium a couple years ago that Sahej Khalsi put on. And it was looking at cultural humility, but implicit bias was not something I really thought about much in EMS education. But the example I'm about to say is getting better with the newer editions of textbooks I've seen. But I went back and looked at some EMS textbooks from 10 years ago, and every picture in the book, for the most part, was Caucasian. There wasn't a lot of talk about ethnic diversity. There wasn't a lot of talk about different clinical findings that are just viewed differently based on skin color, skin tone. Cultural humility was part of that as well. Understanding different cultures and how to interact with those cultures. It wasn't not a big part of the textbooks a while ago. So was that putting in another level of implicit bias into our health education, where we weren't really preparing our students for what they might experience in the field? You can see number 7, we did retain the behavioral health concerns. And I do think, and the more I think about this, I probably, if I was scoring this, would have scored that one higher myself if I was one of the panelists on this paper, because it's becoming a very large portion of calls that we do. And I think that we are doing a disservice to the public health systems by not training our providers a little bit better on how to deal with these emergencies. We are starting to see nationally, there are some areas that are trying to send social workers or clinical psychologists to some non-emergent EDP type calls, but EMS providers are often still first on scene. And we do need, I think, to be able to educate our providers a little better for their own safety, but probably as important, the patient outcomes. We don't want to do something wrong simply through our own ignorance, because we don't know what we don't know. Number 8 is interesting to me as well, the public perception of the EMS profession and the EMS education system. Public perception of EMS in the United States is an interesting topic. I like to tell students in classes I'm teaching that if you watch Chicago Fire or any of the Hollywood based EMS or emergency services shows, don't expect that you're going to be traking somebody with a ballpoint pen and a pocket knife on every shift, right? There is a little bit of a disconnect between the realities of the job and what we do day to day. Another part that you could think about that is, if you look at your EMT textbook, there isn't a lot in there about interfacility transfers and discharges and dialysis transports. The kind of stuff that in a lot of EMS systems make up the majority of the day for some of our crews. We train them to take care of stop the bleed and ventilating patients and placing supraglottic airways, putting on tourniquets, intubation, giving a lot of meds. But for a lot of our providers, their day-to-day is transfer work, and they're not really being educated on that. So is that part of the reason that we have such high attrition in EMS? They come in thinking one thing, partially based on Hollywood, sort of reinforced by our educational curriculum and content, They get to the street and that's not what they're doing every day. And they get disillusioned to the profession and they move on. Maybe if you were more out front about what all the aspects of the job, that would make a difference. The affective domain in EMS was retained as well. And affective domain, I think, is important. And it's probably one of the least understood educational cognates in a lot of EMS education, in my personal opinion. Again, not speaking for my research team here, but a lot of places I have seen are simply checking boxes to meet accreditation standards on affective domain. But that type, the affective domain leads to better patient care. If you have a good bedside manner and you are treating patients professionally and appropriately, you have empathy for them, you can be a very competent clinical provider and have good outcomes from your patients. But if your affect is bad, they don't think you did a good job. And that has been proven in studies. They've looked at different areas of healthcare, including physicians, and they found that if you treat patients with good respect, you have a good bedside manner, you're less likely to get litigated against for malpractice, as an example. So I do think affective domain, part of the job is customer service. And how do we teach it, and how, additionally, not identified in the research, but how do we teach it? Then how do we evaluate it? How do we know if our students are getting it? And again, the last one on this was the Association of Program Accreditation Standards with Real-World EMS Practice and Clinical Performance. I talked about that a little bit already. I do think that's an area where we should devote some research funding and some research time and see, what has accreditation done? I think accreditation personally is a good thing, but could it be better? Sure. And how do we make it better? How do we make it more applicable to both student learning outcomes and clinical practice in the field? I think we need to kind of tie those two things together. So what was nice that we found was that 5 of our top 10 gaps were related to things that had been kind of found in the past as knowledge gaps. The defining of entry-level competency of the EMS profession was the highest ranked gap. And I have talked about that one a lot, and that one kind of sat with me pretty well. I think that we do need, again, not to repeat myself, but I do think that we need to understand, both as educators and as clinicians and street providers, what is entry-level competency? What do we mean by that? Is it simply passing a test? Or is it more than that? And additionally, what does it mean for field and clinical practice? What do we expect out of our entry-level competent providers? We don't expect paramedic students coming out of paramedic school to jump on a helicopter and start doing critical care medicine, obviously. But what do we expect them to do? And is it realistic to the education that they're getting? And I think an argument can be made that perhaps there is a gap between what we expect and where the curriculum leads them to coming out. So in some ways, in some circumstances, maybe we're setting our students up for failure in the street because the street is expecting more than what the educational standards are pushing us towards. How do we align those better so that we can promote retention in the workforce, if nothing else, and enhance clinical care ultimately? As I talked about briefly earlier as well, we tend to tie educator performance to outcomes. That is definitely true in Massachusetts. It's definitely true if you're a COA, LOR, or CAP accredited paramedic program. First attempt pass rates matter. They matter a lot. And it's kind of an easy metric to measure people by. Is it the right one? I don't know, but it is one. But we really don't have a set of standards that are agreed upon nationally or even regionally, as I explained, between Massachusetts and New Hampshire, with my personal experience of what those standard requirements are, but yet we're still being measured on the same outcome, right? And did we kind of get ahead of ourselves on that a bit? Should we have an established set of criteria, a standard for our EMS educators as far as their own educational background, their own training and experience, and then use a measuring tool like pass rates versus kind of the slap shot different ways of people becoming instructors, but then still measuring them the same? I think we are doing, personal opinion, we are doing our students a little bit of a disservice, and maybe the public a disservice, by not having a discussion at least about broader educational standards across the board. Things like the NAEMSE Level 1 and Level 2 program are great, and they're accepted in a lot of places now, which is fantastic, but they're not accepted everywhere, as I said before. But why? And I can't even get a good answer in my own states. I don't know why New Hampshire doesn't accept NAEMSE, but Massachusetts doesn't accept the NFA program. Nobody can tell me why, other than they don't, because I don't think that discussion's been had. And I think aligning standards is important. Diversity, equity, access, and inclusion, again, popped up. And as I mentioned, there is a lot of literature, and that the body of literature is growing every month on how disparities of care and outcomes happen in the United States based on ethnicity. And I do think that is an area that EMS has historically lacked behind some of our other healthcare professions in looking at and addressing. Now, I don't believe that you need to have an EMS specific study to prove what we've kind of already known from numerous studies in the other health professions. But studying EMS, I think, is very important as well. We need to get buy-in from our providers. As I mentioned when I attended that culture of humility pre-con, one of the things that was interesting in the first repetition of it, and I remember Sahej saying this, was that he got a lot of feedback over, comments of saying this is just PC BS from people. That has kind of stopped now. People are believing it because, through an iterative process and showing data, it's true. We know there's an issue here. And we need, as professionals, to improve both ourselves and our profession. One way of doing that, increasing diversity within the EMS workforce, could be a way to do it. It's probably an important step in moving us forward. The EMS workforce in the United States, across the country, is not very diverse. It tends to be Anglo and it tends to be male. That has changed. There are areas where there's a lot more ethnic diversity, there's a lot more gender diversity. But across the country, when you look at the larger data set, we are still skewing above the actual demographics of the United States to being a male-dominated and a white male-dominated profession. And if we bring in people with diverse backgrounds and experiences, that could probably help us learn as providers. And that goes true with the workforce of our EMS educators. I think as important, our educators should represent the communities that they're serving a little bit more. There is a gap. A program that I used to teach in, we were in the second highest population of Dominican Republic immigrants in the United States. Probably 80% of the health professions professors and staff were non-Spanish speaking and white. We weren't really representing to our students their lived experiences. And it's a constant struggle to recruit people with the background and education to fill those types of educator roles from those populations, because there's not enough of them in the population to pull from. So it is an issue, but it's something that we can't ignore. And if we continue to address it, we can make improvements over time. And I'm just going to put this slide up. I don't think I need to say anything more about the behavioral health concerns. I've talked about it a lot. I just wanted to give you guys one of the studies that we cited in the paper, which is from the 2019 practice analysis that was published in Peer Hospital Emergency Care, conducted by the National Registry, which said that it was the second most frequent primary or secondary impression in children and the fourth in adults for EMS calls in the United States, but again, covers a couple pages of most of our EMS textbooks. It's an area that we are definitely lacking in. I think this is a call for both research in that area, but also a call for the publishers to kick up that area a little bit more. We know that those are the patients we're taking care of. We should get more education on them. So just to kind of summarize and wrap up, there's about 14 minutes left. We came up with a total of 77 knowledge gaps. And as I said earlier, the immediate importance scores on the knowledge on all 77, when we broke them down to the top 30, they were still all really tight. And I would argue, and the research team agreed with this as well, that all 77 are probably areas that can be identified as gaps that should be prioritized for research. The top 10 gaps we just talked about, I think if you read the paper, you get the full list of the 30 and the top 10. If we have any budding researchers in the audience, I think any graduate students, people looking to explore research, some of these are probably pretty easy to start doing some small level research on and start adding to the literature to try to identify some of the problems and some of the issues and what we're doing well, right? Doesn't necessarily mean that if you do research on any of these, you're going to change practice. Probably shouldn't change practice based on a single study anyway, but it is a way that will, give us a little bit more insight and maybe spur some of the funding resources out there to do larger studies or national studies. We really want this research agenda to guide researchers and funding so we can get more effective use of the resources and research capacity of EMS. Educational research, again, there is not a lot out there in EMS in the United States, and I hope that this paper gives you guys some ideas of things you can look at and maybe create some discussion. We did present the initial findings of this paper at the NAEMSE symposium 2 years ago before it was published, and it was pretty well received. I did receive a lot of requests to look at some of the stuff before it was published. But again, now that the paper is published in JSEP, please go to JSEP, take a look. I would love to answer any questions you guys have. There's nothing in the chat yet, but I'm staring at it. So please feel free to ask any questions. And I'll kick it back over to Rio.
Thank you so much, Scott. So while we wait for any questions to come in here, I will drop a link in the chat for everybody to access the CEU registration. And we can just wait another couple minutes here to see if there's any questions.
Thank you, Jacqueline. Anybody who's still in the room, I just dropped the PubMed link to the article if you want to just grab it real quick. Probably should have thought to do that earlier. Sorry about that.
That's not a problem at all. I can also make sure that I include that in tomorrow's follow-up email as well.
That'd be great.
Yeah, awesome. So I don't see any other questions. So in that case, that brings us to the conclusion of the webinar. Scott, thank you so much for being here to present today. You are fantastic. Everybody, thank you so much for attending today. And we will see you next time, all right? So everybody have a great rest of your day.
Thanks for having me.